Hello everyone. Welcome to our first clinical training webinar for the CT eLC QI project. We are very excited for this webinar today. We have a guest faculty speaker in the wings waiting to speak with you. We're very excited to have her. This webinar today is focused on establishing a welcoming environment for adolescent patients. And without further ado, I would like to introduce our faculty speaker today, Katie Shala-Leshak. I actually had the pleasure of seeing Katie speak at a National Adolescent Conference in Michigan last year, and I was incredibly impressed by her talk, and I asked her if she would be willing to be a faculty for our project. Katie is a child health consultant with the Minnesota Department of Health. Her clinical background is in primary care as a pediatric nurse practitioner. She provides statewide training in Minnesota, as well as consultation and technical assistance for child preventive health screenings for primary care providers and other child health screening professionals. And without further ado, Katie, I'd like to hand it over to you.
All right, thank you. It's nice to be here with you all, and I appreciate the invitation to share what I've learned and what our state has learned around adolescent and young adult-centered or friendly care and welcoming environments. I'm counting on you to let me know if you can't hear me well, but I'll just go ahead and launch in. So as you've been told, I am a pediatric nurse practitioner. My background is in primary care in both school-based health and general pediatrics. And currently I work with the health department, so my job is to support primary care clinics around the state around our state's version of the federal EPSDT program, which is Medicaid's comprehensive benefit for preventive care for kids across the country. And so in Minnesota we call that program Child and Teen Checkups. So our work has a lot to do with setting up policy, but also supporting providers to provide evidence-based and high-quality care for kids that are eligible for Medicaid. But as it turns out, clinics like to provide the same standard of care across their clinics regardless of payment plans. That ends up involving all kids who are receiving care, whether or not they're on Medicaid or privately insured or uninsured. So I'll tell you a little bit more about myself. I have to tell you, it feels funny to be named as a so-called expert in adolescent health, because that is certainly not how I would have viewed myself probably a year or two ago. My area of specialty was in early childhood and in developmental and mental health for kids. So I am a relatively recent convert to adolescent care. And so I'm going to share with you some work that we've done in Minnesota, but I'm also going to be kind of honest about my own personal journey in this area, and I hope that it will be relevant for a lot of you. I know there's a variety of people who are on the webinar right now, and you probably range from adolescent health experts yourself, people who are really comfortable and enjoy working with adolescents, all the way to primary care providers who may be less comfortable or less familiar in doing adolescent care. And I know in my work, both at my own clinic where I've worked, but also my work with other clinics around the state, that there is a pretty big chunk of providers out there who are not only uncomfortable, but even resistant to talking about sexual health and other sensitive issues. So I'm just going to highlight experiences and tools as we go through that have helped us address those concerns as well. I don't have anything to disclose in terms of financial or other disclosures. So I want to cover two areas. One is, what are youth-identified values? What do young people say will bring them in for care? Not only bring them in the first place, but keep them coming back if they experience that. And then secondly, we want to talk about clinic-tested approaches and tools, so tools that actually have been found to work in a clinic setting, a busy clinic setting, to efficiently provide care that is centered on the young person that's visiting for that care. So when we think about adolescent development, I think it's really important both for providers and parents and young people themselves to have a broad understanding of what adolescent development is about. I think in a general primary care setting or among parents, people get pretty excited about toddler milestones, like your first words, your first steps. It's viewed as cute, it can be annoying, but generally we celebrate the milestones of young kids. And my point with this slide is not to go through each of these developmental milestones, but just to recognize the huge range of things that young people go through as their bodies and their brains and their emotions and their relationships are maturing. I think a lot of times in clinic we tend to focus on the risk factors, like around sexual health or chemical health or behavioral health, but at the same time young people are moving from really concrete thinking into much more abstract thinking, meaning that they can move past themselves and start caring about the world around them. They start to get really interested in politics and volunteering. Their relationships are undergoing a huge transformation. So they've kind of already got their immediate family figured out, and now they're trying to figure out how to survive and thrive in a world with their peers. And I think all of us have some memories from early in our life that help us sympathize with that. There's also, I think importantly, especially in the clinic setting, this transition from being very dependent on their parents or adult caregivers into a more mature and independent role of learning how to take charge of their own health. And so as we talk about youth-centered care and a welcoming environment, everything we're talking about is really designed to help young people come along in that transition and start to take charge of their own health and feel like they have some choice in that matter. So, we'll wrap this up later and you'll understand why I'm asking you this very important question. Okay, so stepping back to adolescent health, we looked at our state Medicaid claims data, and this is our most recent year, and you can see, so this is the proportion of kids who are Medicaid eligible in Minnesota who had at least one checkup in the past year. And so, as you can see, for infants and toddlers, for infants under a year, over 90% are getting in for a checkup, and we hope so, because they have probably 6 checkups due in a year. By the time you get over to 19 and 20-year-olds, it's less than 20% came in for a checkup at all in that year, and that's with checkups being recommended on a yearly basis. And so the question is, why don't adolescents and young people come in for preventive health visits? So you've got your coffee order in. So I'll tell you, Minnesota worked with several other states in this national collaborative improvement project to really look at how do we get rates of adolescent well visits up? How do we get them in? And in the first rendition of this project, some focus groups were done in Iowa. And I know Minnesota and Iowa probably feel pretty far away from you right now, but I think we deal with a lot of similar issues in a lot of ways. What parents and young people in these focus groups said is that they didn't even know well visits were a thing at this age. Like, they understood that babies were supposed to come in for checkups and shots, but they didn't even know that well visits were a thing for adolescents and young adults. And again, the key thing that came up is, why would I go to the doctor if I'm not sick? Maybe if I needed a sports physical, maybe if I had asthma and I needed some medication refills, maybe if I was acutely sick, then I would come in. But we wanted, so that's for preventive health visits. I think it's important too to think about, there are times when young people feel like there is something going on. They have a concern that they want to get checked out, and yet we know there's a pretty huge rate of young people that forego care, so they don't show up or don't access care even though they want to. So this slide shows you some information about that. About 1 in 5 adolescents in the U.S. report foregoing care they thought was necessary. Confidentiality concerns are a huge factor, particularly if it has to do with psychological distress or what we could euphemistically describe as health risk behavior, so having to do with sexual health or chemical health. And so, kind of on the flip side, we know from research that if young people know that they can expect confidentiality, then they're much more likely to share what their concerns are. They want to be asked, and confidentiality helps with that. I think it's also really important to pay attention to equity around foregone care. Rural adolescents are more likely to forego care. That's 44%, that's almost half. Trans youth, the numbers are pretty huge in terms of how often they're not accessing care, even if they wish they could or would like to. And then sexual minority youth in general, LGBTQ plus kids, a lot of foregone mental health or physical health care as well. So in Minnesota, what we really wanted to do was look at what do young people say about that. We had some ideas, as you have. They kind of fall in. You could, if you needed to categorize them, you could put them into these two categories. One has to do with feeling comfortable or welcome or just ready to do it. And then the second piece has a little bit more to do with convenience or access, when and where they need to get it. Highlighting some things related to comfort. We talked about kids feeling shy or scared. Oftentimes, especially if there's a particular issue, like a so-called health risk behavior, they may be embarrassed to be seen at the clinic, or they might be embarrassed because it seems like it's mostly designed for young kids. There's definitely the fear of medical procedures. Pelvic exams are not a part of well visits anymore, and oftentimes are not needed for reproductive health care or sexual health care, but a lot of young people don't know that. Young people are concerned about privacy and confidentiality. We know that for sure, based on lots of different types of research. And I think a lot of it really comes down to not feeling welcome. So the staff feel unfriendly or cold or not welcoming. And then in terms of convenience or access, young people not knowing for sure where they can go to get what they need, or what they can access on their own. The hours are, clinics are open during school hours and after school activity hours, but not so much on evenings and weekends. Difficulty with transportation, especially if they're trying to get to a clinic on their own. And then the cost, not being sure if services are covered or not understanding really at all how the whole health insurance works, or who pays if somebody, or if somebody has to pay. Or if they know that they're uninsured or undocumented or any of those things, they may have extra concerns about cost as well. So the question is really, so these were our ideas, right, that you all chatted into the box. We've just discussed, we've talked about research results, but we wanted to know in Minnesota, if you talk to young people, what do they say would bring value to them in a well visit? If they knew what was offered or what could be offered, what is it that would actually bring them in for a visit, and then what would keep them coming back for more care? And so we participated in the Adolescent and Young Adult Health Collaborative Innovation and Improvement Network, otherwise known as the IACOIN. And this was run by the Adolescent and Young Adult National Health Resource Center, which includes AMCHIP, the Association of Maternal Child Health Programs, and the University of California and Vermont. So it's a bunch of different organizations that have lots of expertise in both adolescent care and quality improvement. So we worked with another seven states on a common aim, and the aim was to increase attendance at well visits and to improve the quality of those visits. So in Minnesota, we partnered with two different health systems that had several different clinics that participated actively with us. We also worked directly with our state's chapter of the American Academy of Pediatrics and Family Medicine. And we worked with our local public health because in Minnesota, they do outreach to clinics and to families to get them to come in for well visits. We had a lot of collaboration between our Department of Health, which is where I sit, and Human Services, which is where the Medicaid policy and payment sits. And most importantly, we engaged a group of young people in our project. So we actually paid them a per hour stipend to be involved in helping us plan the project from the beginning. We put out an application. We got an enormous number of applicants. It was, when I say application, I'm talking about a one-page online survey. It wasn't too difficult. But our goal was to get a diverse group of people from different cultural and ethnic backgrounds and different geographic locations in the state, and diversity in terms of gender or sexual identity as well. And so from here on out, I'm going to focus in on a few of our key learnings in this project, starting with what we learned from the young people. So these are some photos of the young people that were served as our advisory team throughout our project. When we first met, we had a full-day kickoff retreat with these young people, and we really, sorry, I'll bring you back to them so you can be thinking about these young people sitting around the table. So we shared with them what is available at a well visit. We went through a number of visualization or writing activities where they basically described in a lot of detail what their last experience was going to the clinic for a well visit or for something else. What did it smell like? How did they feel? What did people say when they walked into the waiting room? What services did they experience? What did they wish they could have experienced? So we walked through this whole process with them, and then went through and started thinking about, well, if we could design what our well visit would look like and how our experience would be, these are some of the priorities. And so I'll share that with you as we go forward. I would say the number one thing that came in that conversation is that when I go to the clinic, I want to be able to have a conversation with the provider. So they weren't asking for a cappuccino bar, they weren't asking for whatever, yoga classes, they weren't asking for anything special. They just wanted to be treated as an individual who had unique characteristics and who had both strengths and concerns. So really they wanted a conversation. You know, don't have the doctor looking at the computer the whole time while they're talking to me. The second thing that came out really loud and clear was the importance of what one of them described as cultural humility, but when we dug into that more, this is what they were talking about. It was basically the concept of when you meet a new young person, you need to drop your assumptions. So when you see the chart, you look at their name and you make an assumption about their cultural heritage, possibly about their religion, possibly about their language or their preferences. Same thing when you look at a person and how they're dressed. When you see them and you make an assumption about their race and what that means in terms of their preferences or activities or behavior. For gender and sexuality in particular, they really emphasize the importance of using neutral language around gender until you understand what the young person's gender identity is, and not assuming that someone with a so-called female name or appearance identifies as female and vice versa. We talked some about the non-binary nature that a lot of adults, especially depending on generation, are not necessarily as familiar with. And then similarly for sexuality, in getting a sexual history, not assuming who they're interested in being with depending on how they appear. Also not assuming what kind of experiences they have or have not had based on how they appear. And so to me, that was interesting. Again, I told you, I'm into, I've been into early childhood. I'll be even more frank with you and just tell you, when I presented at the conference in Michigan, I co-presented with our adolescent health coordinator, and she described herself as an expert in sexual health, and I thought to myself, I'm an expert in don't talk about sex until marriage. So I grew up in a really conservative family. We did not openly talk about that stuff. I did not experience stellar sex education. And so, again, coming back to just my personal journey as a primary care provider who is not a natural-born adolescent expert in health, it was really impactful for me to sit in a room full of young people describing this. And I thought, if what they want is a real conversation, I can totally do that. That's what I'm all about. I care about people, and I want to have that conversation too. It's just that it's hard in the clinic where everything is so fast-paced and you don't have a lot of time. And then the other pieces around cultural humility, those are things that I have been working on and learning a lot about already, and it's just those are skills that you practice. Another group of young people were engaged separately for we were going to market statewide just the idea that well visits were available free of charge to young people and families around the state. And so we engaged younger adolescents in online focus groups to figure out what we should emphasize in the marketing campaign. And the top two priority areas that were identified by young people were sexual health and mental health. So they wanted, when they went into the clinic, they wanted to know that they would be able to talk to their provider privately and without judgment about their questions about sex and sexual health. And they wanted to be able to talk about mental health and emotional well-being, whether it was their own mental health or issues that they were dealing with their family or friends. And so we did design, the young people helped design this emoji equation marketing campaign for well visits just to increase awareness. But we also took that to heart as we worked on training with providers and establishing resources to share with providers around the state as they provide preventive health visits. All right, and one thing I think is just one of the public health nurses brought this up in our process. They said, what if we called this a checkup, or a check-in instead of a checkup? And I just like that idea, because if you're checking in with someone, you're just kind of getting an update and you're catching up on what's new, whereas a checkup sounds like you're bringing your car in for its 90,000-mile tune-up. It's a very different concept. So that helped shape our thinking. Great. Sounds like someone needs to hit the mute button on their end. So please go ahead and go on mute unless you are need to say something. So now we are back to your coffee orders that you placed earlier. I wish I could bring you each the cup of coffee that you wanted for yourself or your green tea. So at this one-day retreat, we were halfway through the day. People were really engaged, but after lunch it gets a little sluggish, and so I needed a cup of coffee, and I thought, well, I can't drink a cup of coffee unless I get coffee for everyone. So I sent around this piece of paper and just said, let me know what coffee do you want? Because of course I had thought about going to the coffee shop and just picking up one of those boxes to go, but nobody actually likes that stuff very much. So I gave them the sheet of paper and asked them to pass it around, and I just got this blank look from the first young person. And so I said, no, really, just write down whatever you want. It's fine. Like, we have extra money to pay for it. Which we didn't really, but I was just trying to get them to the point of being willing to write down a coffee order. So after a couple of times of encouraging this, they passed the list around, and this is the actual coffee request that came back from each of the individuals who were involved. And my personal favorite, is Jeremy's order down here. He wanted a medium hot white chocolate mocha with 4 extra shots of espresso, 2% milk, whipped cream on top, 2 sugar packets, sure in the raw if they have it, and 1 stir stick. So this is a young person who knows what they want, clearly. And this was, it was funny. It was great. Everyone got their coffee. It all got drank because everyone got what they wanted. But this really helped us think in a different way, or in a very practical way, about what does it mean when we say patient-centered care or youth-centered care. And to me, I guess based on this, if you walk into a coffee shop, they could give you a cup of black coffee, but 9 times out of 10, that's not going to be what you actually wished for or necessarily what you came there for. And when young people come into a clinic, they may expect to get run-of-the-mill care, and in fact, probably based on their past experience, that may be what they've gotten. But when they come into healthcare, what they could get is what they actually need and want. And so that's the concept of figuring out what is this individual about, what is it that they want to get out of today's visit, and how do we learn more about who they are and what they need and tailor our care to that. So that's the concept of coffee-centered care, now that we're all thinking about coffee. Again, for me, both as a provider and as someone who's responsible for doing statewide training, this transformed my own thinking, and I'd say the same as well of the clinics that were involved in this process. So what we learned from the young people was just this idea of, in general, if you're a primary care provider, you have a list of things that must get done at a visit in order to be able to code and bill for a well visit or whatever it is. We have our J-code stuff, we have our clinical quality reporting measures, we have our evidence-based care, and so there's a tendency to focus on just checking the boxes and getting that done. So if what we want is to end up with youth-centered care, that's a more meaningful visit that really supports adolescent development and their transition and taking charge of their health. What we wanted to use to transform that care were tools or strategies that were recommended by young people that had been tested and actually worked for clinics that meet existing quality measures. So it meets Bright Futures standards, it meets your clinical requirements that your coding folks are looking at, and it uses free tools. We didn't want to add on anything that clinics had to purchase. So that was our goal for the rest of the project then. So that all sounds lovely, but clinics are a busy place. You have to really think about clinic flow. And so the question is, how do you provide a caring, meaningful visit for young people that's individualized to them in a way that's doable? And so these are the steps that we're going to highlight coming up. Number one is looking at your clinic setting and staff and just thinking about what can be done to ensure that it is youth-friendly and welcoming. The second thing, which I'm not going to go into in detail, but is critically important, is being reasonable with scheduling. I still work in a clinic, and on a Saturday when they schedule me with 20-minute adolescent well visits back-to-back, I can guarantee you I'll be way behind by the end. So you kind of need to alternate the ear infection with the well visits, or maybe a lot of clinics are scheduling longer visits for adolescents. So there are different things that can be done to make this possible that clinics are doing. The third thing, which is what young people want, is ensuring that every young person who comes to the clinic gets one-to-one time with their provider, where they can have a real conversation and that they're able to talk about important issues, even ones that are sensitive or confidential. And then the final thing is, what are the tools that support that visit? So when a provider walks in a room, if everything is ready to go, so if we already have a mental health screening tool that's completed, if we already have a sense for what some of their health strengths and possible risk behaviors are, if the family health history form or information is already gathered by the time they walk in the room, then the provider already has an idea. They have a jumping off point. They are able to really focus the visit in on what this young person needs. And so that has to do with pre-visit planning and making sure that the front desk staff and the rooming staff really know what needs to be done at each visit and can help support that in an efficient way. So starting again with the first factor, which is really looking at this youth-friendly people in place. In our project, what we did is use an existing, sorry, give me a moment. I need to check my, I just realized it looks like in our slides somehow there's one thing missing here. So I'm going to share about that. It is in your documents to download, or sorry, your important links. If you look over there, you're going to see a youth-led health center assessment tool. And so that is the first tool we used. It came from the University of Michigan, their Adolescent Health Initiative, and the young people whose pictures I showed you before teamed up with clinics to do an actual tour of the clinic. And so they went through, they met some of the staff, they looked at the waiting room, they looked at the exam rooms and learned about the process. And so they went through this checklist and they came up with some specific findings that they recommended. And pardon me as I kind of swipe through the slides in different order. So hold on, I'm sorry. Okay, it's not there. So the what they learned, I'll just tell you verbally what they learned. One thing is that it was not clear coming in that this place was designed for young people. So they wanted to see more materials. You all talked about posters on the wall or something that indicates that this place is not just for babies. The other thing, another example of what they learned is that when they walked into one of the clinics, even though there's a doctor there who had a specific had specific expertise in working with LGBTQ youth. There was no indication whatsoever when he walked into the clinic that this was a friendly or welcoming place for kids with a different non-heterosexual, non-binary, or transgender young people. And so that was something that they had just not noticed before. So the clinic managers were actually very excited to do this walkthrough with young people, so I would encourage all of you to consider that. Getting high school students or college students, they can do it for a special project for school or whatever, using that youth-led health center assessment tool as a way to learn more about what can be done. In our clinics, because they were big health systems, they had rules about what they could put up on the walls. And so instead of using posters, the young people ended up helping them develop a youth resource flip chart that they could look at in the exam room or in the waiting room. So that really helped increase the usefulness of that waiting time. One of the best used tools was this. They had a guide on what birth control methods work best. They had a nice visual on that. There was information in there, one called Do Ask, Do Tell, so that's a free national resource that you can print off and just laminate. So we ended up going old-fashioned in a lot of this stuff. So I know it seems kind of crazy that a flip chart is something that young people would recommend, but they really did like this idea, and the clinics have implemented this, and they've gotten young people asking questions about the content in there. All right, I'm going to go back now to the surveys. The other thing that our participating clinics did was implement adolescent and young adult satisfaction surveys. So every young person's visit, they got a survey depending on their age, and it was available in English or Spanish, where they were able to describe and rate their visit for the day. So that included a lot of questions about, was it clear to you what the confidentiality practices are? Did you feel heard? Did you get a chance to answer all your questions? We did learn after trying the phone version, the QR scan version, the bit.ly link version. We tried to do this electronically. It just did not work. And again, what worked was the old-fashioned way of giving out a paper survey to the young person at the end of the visit and having them just put it in the envelope on their way out of the room. And so those surveys are available online. They're actually most easily accessible from our Child and Teen Checkups website, and that's the link you see there. But they're not designed by us. We use them with the permission from the Adolescent and Young Adult National Resource Center. So a couple of things we learned. This just gives you an idea of what we learned. For young kids, so 10 to 13, that's how young the surveys went, they really liked having a chance to talk to the doctor on their own. And it wasn't too uncommon to hear, thanks for the check of the private areas because I was worried. So again, going back to adolescent development and early adolescence, you're going through these body changes and you're really wondering, am I normal or is something crazy happening here? For 14 to 17-year-olds, there was really a lot of feedback about wanting and appreciating time to talk privately with their doctor and feeling safe to do that. And then also saying, I need more time. I need a chance to talk in private because you can see this person said, I felt as though my mom was a little overbearing. And so these surveys actually are what moved the resistant clinicians in the practice to be on board with this confidentiality concept and having the one-to-one time. So this is where the surveys were really critical, not only in generally improving and making the care more youth-friendly, but in moving the flow to adopt providers to be more willing to implement these practices. And then for young adults, liking that they were treated as an adult with an opinion and their own choices. And of course, what could have made it better for everyone probably would have been puppies, maybe a cup of coffee. All right, so we've already done the flip chart. I apologize, I missed that as I was going through my slides. Minors' consent I'm not going to go into in great depth because it'll be a part of your future webinars. But I will say, if you're focusing on creating a youth-friendly and welcoming and safe environment, it's critical that all staff have a good understanding of minors' consent, which is what minors are able to consent to on their own, even without parent permission, and confidentiality, which is a separate concept. How do we keep that information private? Both are protected by federal and state law, There's huge variation by state, and I won't go into great detail on that, but it depends both on, depending on the state, there may be different requirements for different ages or for different areas of care. For example, sexual health versus substance use or mental health or emergency care. And so there are some links there for Louisiana and California specific resources. Just as an example, people needed help with scripting about how do I talk about confidential care, because that is one thing we learned. It's really critical to explain not only to young people but also to their parents that we do have confidential conversations in here, and this is based on our state law. But in starting a one-to-one conversation with the young person, you would let them know that what we talk about is private between me and you, and other staff only on a need-to-know basis, but that there are also exceptions. So if I learn that either someone is hurting you or that you may be hurting someone else, then I will need to bring someone else, and you and I will talk together to figure out how to approach that. And so it doesn't have to be word for word, but getting in both the concepts of this is confidential, this is private, but also there are exceptions, and then the young person can decide what they're ready and willing to share and won't necessarily be surprised later. So I'm moving a little fast, mainly because I want to spend a little bit of time on setting one-to-one time as a clinic standard. We did learn through provider surveys in our participating clinics that there was tremendous variability around whether young people were consistently offered one-to-one time and at what age. So we had providers where it ranged from 12 or 13 years of age all the way up to 18 or 21. Or there was even one provider in the practice who did not ensure one-to-one time or confidential time with the patient, even when their patient was already a young adult. And so we had a lot of work to do in that area. And I'm guessing our clinics weren't alone in that respect. So a quick poll again. So why one-to-one time is so important for our young people? What they said mainly because that's what creates value in the visit for them. They want to be listened to, they want their individuality respected, and they want to know that they have confidential time. That one-to-one time is when they learn how to and practice asking their own questions, and so that's really what helps them with transitioning into adult care. Is by the time they hit 18, they're already well-versed and practiced in how to get what they need for their health. And also, importantly, one-to-one time is really critical if you're going to respect their right to minors' consent and confidentiality. One-to-one time is also important from a parent perspective, though. So I want to be clear that when we talk about one-to-one time or confidentiality, we're not talking about kicking the parent out of the room. The parent is an expert on their own child, but they also need a lot of support because parenting an adolescent, if any of you have done that, is challenging. And so giving them a chance to do that. One critical thing, this is, if you walk away with nothing else, this is one thing I'd like you to pay attention to, is this was a tip from our young people in our group. Instead of asking the patient if they want their parent to leave the room, just have the provider let the parent and patient know that now it's time for that one-to-one time. Because when you ask the patient, it really puts all the pressure on the young person, when the pressure should really be on the provider to explain that now it's time for us to have that conversation. I also recommend, if you're able to figure it out, and I've done this too in my practice, is make sure you give the parent a couple of minutes to talk with you alone as well, because sometimes they have questions that they have a hard time asking in front of their child. As a resource, this article is excellent, and you can access it for free online. And it's really looking at how do you provide adolescent care that honors confidentiality while still engaging the family and meeting the family's needs around adolescent development. So I'd encourage you to take a look at that. Another key tool that we developed as a result of this project, we had an older version of this health questionnaire, but because of this project, we updated it. And this is probably our core clinical tool at the time of the visit. So while the parent gets the family health history to complete, the young person starting at age 11 gets this questionnaire that they complete on their own without help from their parent or their friend or whoever came along with them. And so this clinic looks both at strengths and health risks. At the top of the form, they self-identify their name and gender, so that's a clue. It also gives them a chance to say what they want out of the visit, and sometimes they just want a sports physical form, sometimes they just want to get it over with, but sometimes they have a particular health issue that they're concerned about. And then this top section, so in these top 8 questions, if the answer is a yes, that's an encouraging thing. So this has to do with nutrition and exercise and having an adult you can talk to. And then below the line, so that providers can quickly at a glance see what is needed. If it's a yes or a sometimes here below the line, then that means that the provider needs to ask some more questions. So these are potential health risks. And basically, the farther you get on the form, the more likely you are to be in confidential zone or minor's consent zone. And it's pretty clearly explained here to the young person that your answers are private, but if we learn that someone is possibly getting hurt, then we do need to engage someone else in the conversation. So it explains some of that for you. So the idea of this questionnaire is by the time the young person walks in the room, you already know a lot about their nutrition, their exercise, their family, how school is going, and sexual health questions, substance use questions, and that sort of thing. So it's definitely something I encourage you to take a close look at afterwards, that it's in your documents to download. And there's also on our website this clinical guidance, and I would very much encourage you to review the guidance, because this type of health questionnaire, really you end up with a lot of questions from providers, parents, and young people. And so the clinical guidance goes into detail about what you need to know ahead of time and how to present this to the family and to the young person. On the back of the form, there's also a validated, the S2BI, validated substance use risk assessment question with vaping and other substances added. So that is available to you to look at. I do recommend that if you're going to implement the adolescent and young adult health questionnaire, and in general with one-to-one time, that you establish a practice of giving out a clinic letter to share with families and young people about what your clinic standard is, because that way families aren't surprised when you introduce one-to-one time during the visit. They won't be surprised later on to learn that HIV screening is a part of it, or that chlamydia screening is a part of it. So that clinic letter is a critical piece. We talked a lot about the front desk staff and the rooming staff preparing the young person for the visit. Well, let me step back just a moment. I want to mention that the provider just needs to remember, if they're going to use that questionnaire, that even though they want to engage the parent in conversations and anticipatory guidance around substance use and that sort of thing, they need to remember to wait until one-to-one time with the patient to discuss any items on the questionnaire that are confidential or covered under minor's consent. On our website, we collected a lot of adolescent-specific preventive health resources. I won't go through these individually, but of course you're welcome to go and take a look at what those are. And so this was part of our process of making sure that clinics in Minnesota had access to some resources that could help them implement high-quality care for young people, including confidential care, in a way that was efficient and possible to do in our busy primary care setting. And when I say possible, I say that with a grain of salt. It's really difficult, to do a great job of adolescent well visits in the constraints of time that we're given. But some take-home points from our Minnesota experience. One is that young people do find value and having the opportunity to have a good visit with a healthcare provider. Number one, they want you to talk to them and get to know what their individual strengths and concerns are. And you can do that obviously through conversation, but you can also use some of these clinical tools to get at that. And it's worth investing in your clinic setting, your staff, to make sure everyone's ready to provide care that is welcoming and comfortable for young people. The second take-home is setting a clinic standard to make sure every young person, I would say starting at 11, because that's when Bright Futures recommends starting to do substance use risk assessment and sexual STI risk assessment, so those are confidential services. So that's when you want to start with the one-on-one time. And then there are free and clinic-tested tools that are available for use, both to do that clinic assessment to see how youth-friendly you are, but also to do adolescent surveys or provide those effective and efficient screenings. So overall, in summary, you're using implementation strategies that build comfort. We've talked a lot about these things. How are you inclusive in the language that you use, that cultural humility that we talked about earlier, getting to know them and what did they want to get out of this visit. We've talked about focusing on strengths, not just looking at the, sex, drugs, and rock and roll, but really focusing on their development, what interests them and what their strengths are and their health goals. We didn't dive into this, but this is critical, the concept of trauma-informed care. Many of the young people that we see in clinic haven't experienced traumatic experiences either in their earlier childhood or currently. And so really, before we make a judgment about why a kid is behaving some way or is so-called non-compliant, we really need to look first at ourselves and how we're making a space that's safe for young people who may experience trauma. So that could be a whole separate discussion. Being client-centered, and that has to do a lot with being ready to provide the care that they need. So if you're going to be doing substance use screening, you need to be ready then to help them take the next steps and that sort of thing. Creating that pleasant physical space. It really is helpful and transformative to engage young people in your processes. So I would definitely encourage that. You can use those tools that we described. But a key thing that they brought up is this using the waiting time as an opportunity. So make that time worthwhile. Give them stuff they can look at, like one of those flip charts or other tools, resources that you may have, so they don't feel like they're wasting time sitting in the waiting room. And then we have just the basic convenience and access issues. I think the number one thing that was the problem with our service or our project that we focused on, it was entirely focused on the primary care setting. And really, if we want to reach young people, it's probably best to go where they are. They're at school, they're in different areas in the community. So rethinking how and where we offer that care, rethinking the hours, making sure that there are hours that are available outside of school hours and work hours for young people. And if possible, and this can be harder, creating teen-specific times. I've heard different levels of success that clinics have had with that. But certainly having flexible scheduling. And one thing our young people really asked about, they wanted to have the opportunity to be able to make an appointment on their own without having a parent coming in. And in our state, I'm not sure about California and Louisiana, in our state there's no state law that defines how that happens. It's really up to the clinic to establish a policy. So that's something that our clinics looked at, was deciding, if the kid is whatever, I can't remember what some of them came up with, but like if they're 16 and older and they've already had a visit here, that was one example. But you do want to develop a clinic policy about that to allow young people to come on their own if it's allowable and doable. And we really do need to address both the cost and confidentiality. Obviously, they're separate issues, but they're related. And one of the related aspects is billing, whether or not something is going to show up in their bill. In Minnesota, again, at least in Medicaid, the parents do not receive an explanation of benefits with that level of detail, but that's not the case in all places. So you need to pay attention to that, both what is in the electronic health record and the billing process. So I'm going to pass the baton now for you all to share more about other resources that are available.
Thank you so much, Katie. We really appreciated that. And I'm just going to breeze through some of these resources in the interest of time so we have more time for discussion. But I wanted to share a few of them really quick. I wanted to highlight this resource from CDC. This is an infographic that just identifies different aspects of a teen-friendly sexual reproductive health visit. It's a nice tool that lots of people have seemed to really take advantage of over the years. So I wanted to highlight that. I also wanted to highlight this toolkit from the Adolescent Health Working Group. This group was based in California. However, the tools and the steps and information in this toolkit are really applicable to any setting nationally. And I wanted to highlight our the National QI Center's QI Resource Library. There's the link there. You can also, there's a link on your web page for practices site as well. This has lots and lots of different kinds of implementation tools. Here are a few we noted, some starter guides that came out of Michigan, for example. Some of the tools that Katie spoke of today from Minnesota are in there as well. I wanted to note that we also have example letters you can give to parents. This is the one on the left is a more simplistic kind of version about just your standard teen visits. We also have one that's more of like a formal letter looking type. They're all editable. You can put your own clinic name. You can adjust the language that's in there, but it might be a good starting point if you're thinking about introducing a letter to parents, for example, as one of your Pdsa cycles. And similarly, we have a couple of different types of posters that could be hung up in the exam rooms or what have you that talk a little bit more about confidentiality of care. And all of those are available